so that hopefully you retain the information throughout the rest of the program and your career. I'm going to try not to overwhelm you with stuff that is just beyond your scope of practice or just totally unnecessary. Now, health, wellness, and illness. I mean, that's the business we're in. Health and wellness. As far as terms, I mean, health, Lippincott and ATI will tell you, it is the state of optimal functioning or well-being. It is not merely the absence of disease. So just because a person has type 2 diabetes doesn't mean they can never achieve health or being healthy. If they take their medication, they do their diet, they exercise, they can still achieve optimal functioning. So health is different for different people. Wellness is the actual active process that you are involved in to achieve health. So it's your lifestyle choices. It's, making the decision to work out, 3 times a week. It's not smoking, that kind of stuff. However, those two terms are often just used interchangeably. And if you weren't in nursing school, these definitions, I mean, you wouldn't even be thinking about them. Health, wellness, they go hand in hand. So the aspects of health and wellness, when we're talking about health, when we're talking about wellness, we're talking about everything, holistic. We're looking at the whole person. We're talking about the physical aspect of your health, emotional, social. Do you have a family? Do you have friends? Do you have a social network? Intellectual. What is your education level? Are you educated? Are you undereducated? Spiritual, your spiritual health, obviously that speaks to itself. Occupational health, where do you work? Do you work? Are you unemployed? Do you work in a hazardous environment that exposes you to lots of chemicals, smoke, stuff like that? Environmental, where do you live? Do you live in a rural community where there are no doctor's offices or hospitals? Do you live in a crime-infested community where your life is at risk every time you go outside? That's environmental. Holistic care is just that. It is looking at the whole person, like I just said, looking at all those aspects. And when it comes to nursing, that is what we do, and that is what sets us apart from doctors. Doctors treat diagnoses, medical diagnoses, and I'll even say physician's assistants. Doctors and physician's assistants are trained under a medical model. They are trained to look at you as a diagnosis, whereas nurses, we treat people. The medical model, they don't see James, the African-American 30-year-old male who is a young widow, or what is it, widower? I don't know, widow, because he's widowed, his wife died, whatever. And he's got, 3 kids at home, and he's just trying to make ends meet, and he could barely afford food. They don't see that. They see James, 30-year-old male with diabetes. That's it, that's all. I'm here to treat your diabetes, make sure your diabetes is good, make sure your labs, your hemoglobin A1C, your blood glucose is good, and then you can get the heck out of my office. I don't care about your job, I don't care about your kids, I care about your medical diagnosis because I'm a doctor. And not to say doctors are bad or whatever, but that's their job. That's what they're not here to hear your life story. And that's why they only spend 5 minutes in the room with you, because they know medical diagnoses like the back of their hands. It's us, the nurses, who come behind them and say, you know what, I know you have diabetes, but do you even know what diabetes is? Do you even know how to administer shots to yourself? That's what we do. So there are factors that are influencing health and wellness. That includes the external and the internal environment. The external being anything outside the body. So that social aspects outside the body would be your safety. Do you live in a safe environment? Are you in an abusive relationship? Do you again, live in like a crime infested environment, or do you live somewhere that's having hurricanes every 2 weeks? Finances, politics, social networks. Those are things outside of your body. Physical things outside of your body would be your physical access to healthcare. Is there a hospital? Is there a doctor near you? Do you have transportation to get there? Sanitation. What kind of living conditions are you in? Is your home physically suitable for people to even be living there? Do you have a home? Do you live outside? Availability of clean water. We saw, what was it, like maybe within the last 10 years, where was it, Flint, Michigan, where they had the water issue there, and all these people are getting sick. Those are physical aspects outside of your body that affect your health and wellness. Internal aspects inside your body, inside you, inside your heart, inside your mind. Internal environment includes your life experiences, your cultural and spiritual beliefs. How old are you? What is your developmental stage? What is your education level? What is your level of understanding? Are you a male or a female? Maybe you have some mental illness or something, and you don't even understand, the concept of health and wellness. You don't understand being sick. When we talk about variables, now these you need to know: modifiable versus non-modifiable variables. Variables mean elements, parts, another word for like aspects. But basically, when we talk about health and wellness, things can either be, Things can either be modifiable, meaning they can be changed by the person, or they can be non-modifiable, meaning there's nothing you can do about them. So modifiable, obviously stuff you can change would be, do you smoke? Do you do cocaine every Saturday? I don't know. Do you drink alcohol? Do you exercise? Do you eat at McDonald's every day? Those are things you could change. Other things you can change that people don't think about: blood pressure, cholesterol, even if blood sugar. Even if you have a diagnosis of high blood pressure, your blood pressure can still be controlled with medication, diet, and exercise. Your cholesterol can still be controlled with all of the above. Diabetes and blood sugar can be controlled. So those are still modifiable factors. And then non-modifiable, obviously, I cannot change my race. I can go tanning or I can bleach my skin, but at the end of the day, I cannot change my race. I know this may be a touchy subject, but I know it's 2021. People technically do change their gender, but internally, those organs are still the same. Okay, while you may have an appendage added to your body, a woman does not have a prostate and is not going to produce sperm. So until we get to that point in science, technically you can't completely modify your gender. Genetics, obviously you can't change your genes, can't change your age, and you can't change your developmental stage. I'm pretty sure in Nursing 1, you talked about Maslow's hierarchy of needs. And this is another concept, a theory that you will see on NCLEX and on exams, possibly proctored exams and things like that. I don't know who Maslow was. Don't even get me started lying. It doesn't matter. All you need to know is that guy with the last name Maslow came up with the theory on hierarchy of basic needs. And this is the criteria for what makes it a basic need. That not having it, lack of fulfillment, and not having it could result in some form of illness. Not having or having it can prevent illness, or means that you're healthy. Having it could restore your health, or so you could read, you get it. But basically what it's saying is, first and foremost is the physiologic. If you don't have oxygen, if you don't have a blood pressure, it probably doesn't matter what your self-esteem, if you have high or low self-esteem, if you can't breathe, nobody cares about your self-esteem, you're dead. So the physiologic needs are at the broad base. They are the foundation. They are the lower level needs. That is the bare minimum of the needs that need to be met to keep a person healthy. On top of that, you have safety and security. Safety and security means protection. So not just do I live in a bad neighborhood or, do I live with an abusive partner, but more so also protecting patients from infection is a form of safety and security. When a nurse performs hand hygiene and washes her hands and uses good hand hygiene and changes her gloves prior to patient care, you are providing safety and security and protecting the patient from infection. Love and belonging, self-explanatory. Self-esteem, self-explanatory. Self-actualization is a higher level need, and you must have achieved all the rest of these before you get to self-actualization. And that's basically knowing who you are. I know me, I know myself. So a 6-year-old probably doesn't have self-actualization. That is a higher level need that is accomplished later on in life. Okay, defining illness. What is illness? So back to doctors and nurses. Doctors, they treat diseases, diagnoses, medical diagnoses. When we say disease, we're talking about a pathological process going on inside the body or the mind. Schizophrenia is a disease. Major depression is a disease. Cancer is a disease. Asthma is a disease. But illness is the response of the person to a disease. My level of illness may be different than your level of illness, and we have the same diagnoses. So that's the difference between illness and disease. You have acute illness, which is sudden onset and lasts very short term. And it usually with treatment, you can restore the person's health, hopefully. However, acute illness could also kill you. I mean, if your acute illness is a massive heart attack, that's probably going to kill you. Maybe it could, not probably going to kill you. That sounds terrible, but it could kill you. But that's more so because you have a chronic illness anyways. You didn't get to a massive heart attack without having chronic coronary artery disease. And then chronic illness, lifelong, irreversible illness. It causes permanent disability, requires, constant going to doctors, taking medication long term. However, you can have an exacerbation of a chronic illness and end up with acute on chronic, meaning chronic illness. I have asthma. Asthma is I don't have asthma, I'm just saying, that's my example. Asthma is a chronic illness, but my asthma doesn't really flare up. I use my inhaler very rarely, and so I just have chronic asthma. That moment I have an asthma attack or I end up in the hospital with pneumonia, that is acute on chronic. It is an acute exacerbation. Exacerbation is a fancy word for flare up. It is an acute flare up of my chronic asthma. Response to illness and illness behavior. Just like health and wellness, illness behaviors are influenced by the same factors, basically. Who we are, where we came from, how we grew up, what kind of cultural beliefs we have. Our response to illness is different. Different cultures perceive different illnesses differently. There's just so many things that can influence our response to illness. Some people just choose to live in denial. We're not even going to talk about it. Some cultures, for example, some cultures do not accept mental health and mental illness. They don't accept it. They don't want to talk about it. It's not a thing. For them, maybe they believe in you're possessed by demons if you have schizophrenia, or maybe they believe it's a punishment from God or what have you. But that's just an example of the various responses to illness. So question, the nurse is working with a patient to develop a plan to reduce possible risk factors for mental health problems. Which of the following would the plan most likely address? Select all that apply. So you can put it in the chat or turn on your mic, but somebody give me an answer. Anybody? Anybody?
Oh,
Hey.
I'm just saying hey.
Hey.
No one said you were here teaching. Everything good?
Oh yeah. Uh-huh. Good to see you.
Good to see you. Bye.
I'll come up when I go on lunch.
Okay, cool.
All right. So anybody, oh, I see now. People put their answers in. All right. So you're all wrong. And I'm going to tell you why. When we're working on a plan, we're working on a care plan, we're working on reducing risk, we must look at things that are modifiable. I can't do nothing about your genetics, and I can't do anything with your family history. I can't change those things. Therefore, there's no reason for me to plan anything for your genetics. There's nothing for me to do about that. And there's nothing I can do to your genetics to reduce your risk. So these are the kind of tricky questions you get. And, I'm so far, even last night, nobody got the answer right either. But I'm just trying to show you guys. Oh, whoops. Oh, who put that stress nutrition link? Eileen, look at you showing out. So I'm just trying to, get you guys ready for these proctored exams and NCLEX and get you critically thinking. The question isn't always going to say, hey, what is the modifiable factor here? No, a lot of these questions are just implying stuff. So anyway, moving right along. Assessing health and wellness. So when you're looking at a person, you want to assess their level of health and their level of wellness. You're going to look at all those factors like we talked about, and you're going to do the following. You're going to do a physical assessment, which is self-explanatory, head to toe assessments. You guys did those last semester. And then you're going to evaluate their health perceptions. What are their beliefs? What do they believe is, for example, when someone gets a new diagnosis, what does that diagnosis mean to them? Maybe in their eyes, it's nothing wrong with me. Ain't nothing wrong with me. I don't know what y'all are talking about. You said I got high blood pressure. I don't feel nothing. I feel fine. Well, that's why high blood pressure is a silent killer, because by the time you feel something, it's usually end organ damage. It doesn't usually occur early when you first have hypertension. So evaluating their perception and what they think about health and disease. Identifying risks to health and wellness. So this is where your history taking comes in. This is where the family history and the genetics are important. This is where you find out their social history. Do you smoke? Do you drink? Do you, have multiple sex partners? Those kind of things. Somebody in this chat again? You're feeling right. That's right, Phil. You're feeling a stroke. You might feel that with the high blood pressure. Identifying access to health care. Do they have insurance? Do they have a doctor's office near them? Do they have a big major hospital near them? So identifying access to care is definitely important. And then identifying barriers to adherence. And let me tell you, that is in your book on page, in the MedSurg book. I'll put it in the notes. Look on page 4. And it tells you about identifying obstacles to compliance and adherence. So that would consider their perceptions of illness, their confidence in you as a provider. They may look at you and say, you look young. You look like you don't know anything. Probably how you guys look at me coming in this class. You look young. You don't look like you have any experience or you know anything. Their belief in medicine. Some people that they say it all the time. I don't believe in medicine. I don't believe in it. Okay. And that may be their belief. They don't believe in taking medicine. So are you going to push medicine on someone who's telling you over and over again they don't believe in medicine? Maybe not. You're probably going to try to work on some non-pharmaceutical approaches unless it's absolutely necessary and you need to do some, coaxing and educating. Availability of support systems, family role, finances, those are all things that could be a barrier to health and wellness. Family-centered care, that is what we are providing as well. Because again, we provide holistic care. We don't just pay attention to what's going on with the patient. We look at the bigger picture as nurses, and we're looking at who else is affected by this. When it comes to adults, maybe the roles in the household has had to change because one adult in the home got sick. Maybe you're in your 30s and your husband gets cancer. It happens. Illness or a disease can have an effect on the entire family. When it comes to children and elderly people or disabled people, the family obviously is going to be much more involved in the care. You, as a provider of health, are going to rely more on the family for information. The family is the expert when it comes to their child or family member's health. Don't get me wrong. Families exaggerate. We know this. Some of them are just crazy. Some of them, went to CNA school for 2 weeks and they think they're a nurse. It happens. But at the end of the day, for textbook purposes, the family is the expert. They know that, but really, when you're seeing patients who can't verbalize for themselves what's going on, they really are the experts. They know what this person's normal behaviors are, how much they normally sleep, what color their skin usually is. They know all that, so they are the experts. I don't need to go over how family types vary. It's 2021. It's all types of things going on in this world today. And I don't even got enough time in the class to explain the different types of families. Just know family is what you make it. Some people have no biological family, but they have a great social network of close friends who have become family. So, just be considerate of who are those important people in your patient's lives. Family assessment is the exact same as assessing an individual. You're looking at their history, you're looking at their structure, their roles in the family, how they work with each other, what kind of stress do they have in their external environment, what kind of stressors are going on outside of the family, and then what about internal environment, what kind of stressors they have amongst themselves. So now when you go on to talk about wellness in communities, so we talked about the individual, we talked about families, and now let's talk real quick about communities. When assessing health and wellness in the community, it's going to be a few things you're looking at. Morbidity. Morbidity is the rate at which a disease occurs. For example, and this is a fact, 1 in 13 African Americans has sickle cell trait. 1 in 13 African Americans carries the sickle cell trait. That is a morbidity rate, the rate at which a disease occurs. And then mortality rate would be X% of sickle cell patients will die before the age of 40. X% of sickle cell patients will die before the age of 40. That is a mortality rate. You're looking at the death rate associated to that particular disease. So I'm pretty sure in nursing 1, you discussed Healthy People 2020. And now, it is 2021. So that stuff's kind of outdated and they got a new one out, Healthy People 20 or 30, I think, something like that. But anyways, Healthy People 2020 is an initiative led by the World Health Organization and or is it World Health Organization? I don't know, them people. But anyway, the whole thing about Healthy People 2020 is reducing health disparity and improving health and wellness for the people of the world. Health disparity is the discrepancy that is linked in health with certain communities, certain whether it's an ethnic group, whether it's people who live in a certain region, whatever it is, health disparity. Our goal is to reduce health disparity. Our goal is to enhance health and wellness in communities and in individuals and amongst families. That is our goal. That's what we're here for. That should be why you're going to school, not to get a job and get some money. Because to be honest, it's a hell of a lot easier jobs than nursing, and they pay better too. And I mean, just go look at how much the railroad pays and places like that. You know, you can definitely make a hell of a lot more money with a hell of a lot less work and stress. But next, I want you guys to tell me, can you hear the sound on this video when I play it? Let me know if you cannot hear the sound. Well, when it starts, whenever it starts, somebody, can you hear music? Can you hear this?
Yes.
You can. Okay, good. This is a video just talking about health disparity. It's cutting in and out. Okay. Okay. So for time's sake, this is what I'm gonna do. Let me hold up. I'll be quiet. Hold on. Let me go on to the next slide so it'll stop playing that sound, and then all right. So for the sake of time and for the sake of not having you sit here and listen to some old staticky video, I'm going to skip the videos, but I'm going to tell you this. I had to do the same thing last night. That's why we need to just be together in person, so we don't even have these issues. I'm going to, yeah, it's gonna be posted after class. I'm gonna post the PowerPoint, and then that way you can look and actually see the videos, because there's more videos to come to go with the different diagnoses and stuff. So I encourage you to just check those things out. I try not to use any video. That was the longest video, and it was 5 minutes, but it was basically showing you, like, you saw some of the statistics that's popped up on the screen. Health disparity. There are poor people, people who are living with mental illness, minorities in this country, in, you know, America, the great place we live, whatever you want to call this place. There are people who are just at a huge disadvantage, and they are experiencing health disparities. Those people are dying of diseases that other races aren't dying of, or they are having worse outcomes. That's basically I just wanted you to see what people mean when they're talking about health disparity. And the way we conquer that, and the way we improve health and wellness, promoting health and health promotion and education. Knowledge is power. It is 2021. This ain't the days when, and I'm not saying this to be funny, but I'm just saying, these are not the days when Professor Colia was nursing. These are not the days when even our parents or grandparents were in hospitals. Healthcare is not the same. It is a business. It's all about the money. Let's be for real. We are a nation of consumers, and everything at the end of the day is about money. So people are out here having to take care of themselves. Things that you used to be in the hospital for 2-3 weeks, baby. You had a stroke, we'll get you out of here in 1 to 2 days. And you can go home and you and your family can figure out how to recover from this stroke. And that's what's happening. You have surgery, you get a hip replacement, you up out of bed walking with a walker that day, same day, fresh out the OR, stand up, walk around, hurry up, get out. So it is more of a burden on the patient and their families to work on either restoring their health, but most importantly, prevention. If we can prevent these illnesses, then yes, Eileen says she saw some patients get kicked out without a ride and nowhere to go after. My first year of nursing was like the biggest eye opener for me. I did go into med surg straight out of school because that's what all my instructors told me. I'm so grateful I did because I saw so much and I learned so much. But like within my first year on the floor by myself, I had to discharge this man who was older. He fell, he broke his hip, and he didn't have any insurance, and he just had his hip replaced yesterday. And now I am discharging him to the community. He had no insurance, so therefore the hospital did not set him up with physical therapy or any home care or anything because he had no money to pay for it. This is a business, folks. This is how the world is. Do I agree with it? Hell no. Hell no. I wish we had a better system here in America. It is, and honestly, I think that's why I'm more into teaching now than doing anything involving patient care, because I truly love patient care, but the business aspect of healthcare just totally disgusts me. So it's our job. What the role of the nurse is, as you see here, prevent illness, restore health, facilitate coping with illness, disability, or death. But most importantly, we want to teach people about prevention. Knowledge is power. When you teach people about their health and wellness, if you know better, you'll do better. And those people are empowered knowing about their wellness. Some people literally just don't know. They don't know how to take care of themselves. Some people don't know. They don't even know what diabetes is. They call it the sugar. I got the sugar. They don't even know what it is. Some people tell me all the time, I think I have diabetes because sometimes I get dizzy and then I eat candy and I feel better. I think I have diabetes. No, everybody feels better when they eat candy. So no, that's not diabetes. So people need education. Prevention. So when we talk about prevention, the sugar, you know about the sugar. Everybody had heard that before. Or the pressure. I got pressure. You have hypertension? No, what's that? Oh, I have pressure. Pressure. Anyway, levels of prevention. You have primary, secondary, tertiary. I know you talked about this last semester. Just reiterating, primary is strictly education. Primary is like going into a group and teaching everyone about diet and exercise to reduce risk of obesity. It's about going in and just giving some general education. That is primary prevention. Whereas secondary is once you start conducting any screenings, performing any tests. So say I go to a health fair and they educate me on ways to reduce my risk of high cholesterol, that's primary. And then they draw my blood to check my cholesterol. I don't have high cholesterol, but they're drawing my blood to screen for high cholesterol. That's secondary. That is secondary prevention. So health screenings, going and getting your annual physical, those things are secondary prevention. Tertiary means you have a diagnosis now. You went to the screening, you learned about cholesterol, they checked your blood, and now you have high cholesterol. So tertiary is minimizing any complications or chance of disability with that disease and maintaining the optimal health after diagnosis. So yes, you are obese, but let's work on a exercise and diet plan so that you can lose weight. Tertiary levels of prevention. What the hell? Now it's moving all slow. It's probably gonna scroll through 10 screens. Hold on. Okay. All right. Health promotion, patient education. This is how we prevent. Health promotion is basically targeting, trying to get people psyched up to do things that result in optimal health. So you target appropriate changes in the person's lifestyle and personal habits, or even their environment. Move out of that neighborhood. If you're getting shot at every morning and you got the ability to move, because it's not conducive to your health. Or if you work at that job and your boss, I mean, it's just tearing down your mental health, quit that job. It's 2021, get another job. Health promotion. So it starts before birth, because we start talking to the moms when they're pregnant on what to anticipate for their newborn. And we start talking to moms about the diets that they need to eat so that they have the right nutrients for the newborn. And then it goes on until the day you die. You have screenings. Counseling is another word for education. Counseling and coaching, same as education. Immunizations and vaccines, and then any type of preventative medications, maybe like vitamins or taking a calcium supplement to prevent osteoporosis. Those are preventative medications. When we talk about health promotion across the lifespan in infants and young children, it's more so educating parents, and really you're mostly focused on developmental milestones, making sure that they're meeting those milestones, making sure that they're growing at the right rate and they're getting the nutrition that they need. Of course, health promotion across the lifespan, you're going to talk to everybody about diet and nutrition. When it comes to adolescence, the number one focus is risky behaviors. Now these adolescents are older. You're going to be focused on, abstinence or safe sexual practices. You're going to be focused on just say no to drugs, say no to alcohol, say no to cigarettes, focus on things like that. Focus on, you're going to really be tuned in on their mental health. Are they being bullied? Do they feel depressed? Are they at risk for suicide? These are things health promotion is going to be tailored to for adolescents. For young and middle adults, and again, when we go through it, this is why those Erikson's stages of development are important, because you are tailoring the care to their level of development. And so at the stages that infants and young children are at, obviously they're more dependent on their parents, and you're going to focus on them. Whereas adolescents, they're trying to find that role identity. And so it's really important that they don't fall in with the wrong crowd or start following the wrong behaviors. So that's why your education is tailored to that. Young and middle adults, they're in that intimacy phase, and they're planning families, they want to have babies, those kind of things. That's when you start looking, you tailor your health promotion on that. Again, you're going to be talking about healthy diet and exercise and things like that for a family that's trying to get pregnant. But then you also start seeing screenings. For example, age 21 is the age when a woman should start having pap smears. There is no reason for a woman to have a pap smear prior to 21. And then there's other health screenings during that period, age 40, women start having mammograms, things like that. And then also, young and middle adults start to have some medical problems. So you have to address health promotion and maybe some of that tertiary prevention as far as managing that chronic illness. Older adults are obsessed with their health. They're obsessed with their poop. They're obsessed with everything. So they're going to be more health conscious. They're going to be alerted if they haven't, moved their bowels in 2 days and things like that. So the other thing is their developmental stage is all about integrity versus despair, right? That's what Erikson said. So a lot of your health promotion and things is going to be geared at maintaining their independence, helping them find activities and things like that, help them maintain the highest function that they can and be able to do the most for themselves, and feel like functioning independent adults. So with everything just said, when it comes to, looking at health and wellness, you know about the nursing process, and the first step is assessment. Just like in a court of law, we can't jump straight to the trial if we haven't done an investigation first. So think of your assessment as part of an investigation. You're interrogating the patient about their history and all that, and then you're looking for physical evidence, okay? Subjective data is part of that interview and interrogation process. It is about what experiences and beliefs that patient has. It is what the patient says. So I don't know your health history. I mean, unless you have access to some concrete records, like I have to go off what the patient tells me. So the subjective part of the exam is gathering that interview information. What is your health history? What's your family history? What's your social history? Symptoms. Patient telling you pain. Pain is subjective, and we'll talk about that this afternoon. Pain is a subjective thing. It all comes from what the patient says. I can't look at you and tell that you're nauseous. You have to tell me that. Objective data can be measured. It can be measured. That is the physical evidence backing up, whatever your hypothesis is. So the patient comes in, they're subjectively telling you, I have abdominal pain. And now you do a CAT scan and you see, oh, wow, they have a big old tumor or something in their belly. That CAT scan is, you're collecting objective data. When you do your physical assessment and you're pushing down on their stomach or you're auscultating bowel sounds, that too is objective data. It is something that you can observe or measure through the physical exam or other tests and things like that. This also includes, though, those tools that use interviews, say like a mini mental status exam, where you actually are asking the patient questions, and they are answering questions, but that is still objective. Like if you ask this person and then they get a score of 7 or whatever, then that score, that is still something that's measurable. So I just want you to know that those screening tools that aren't about, getting exact, precise lab values, but you're still gathering information and collecting, a score or something like that, that's still considered objective. You could read through this, I mean, on your own time. I already kind of beat this down, but these are all the things, subjective data. And when you do a health history, say when a patient is newly admitted to the hospital, you want to be all up in their business. You want to know everything. Your demographics, that's like race, age, religion, like on that fin sheet or your face sheet, that if for those of you that do work in a hospital or anything, that demographical data is usually right there, including like where you live and everything. Chief complaint, real quick, is just verbatim. It's just that, chief complaint, what the patient told you they came here for. If a patient is here, what brought you here? Tummy hurts. That's the chief complaint. Tummy hurts. It's not medical terminology. It's not anything. It's just a brief statement, 1 word, 2 words, verbatim, what the patient says their chief complaint is. The PHI or present, HPI, I'm looking on here, reading there. HPI, which is history of present illness, is the narrative backing up that chief complaint. That's where you say, okay, patient complains of abdominal pain times 3 days, accompanied by nausea, vomiting, yada, yada, yada. That's the present health concern illness, or what is usually referred to as HPI, history of present illness. Past health history, family history, those things are self-explanatory. Review of systems, you should have learned this in clinical somewhere. Review of systems is going through each system, each body system, and looking for any symptoms or any signs of anything going wrong. Usually when you go to your doctor's office and they make you fill out that paperwork in the waiting room asking you, they're usually having you do most of the subjective data in the waiting room. Yep, head to toe from the patient's perspective is basically what the review of systems is, like Greg said. And then, you know, then you go on to the rest of this stuff. I feel like it's pretty much all self-explanatory. The only thing is, I put this in parentheses, immunizations. And for the record, we are not going to talk about immunizations until next week. I do want you to start to read. I want you to start trying to work on memorizing when certain immunizations are given. But I want to talk about that when we go to immunity. Versus trying to throw that in here with everything else you need to learn. But when it comes to immunizations with kids, you're going to be, you know, when you take your kids to the doctor, they're going to look at their shot records and see what they need, what's up to date, yada, yada. When it comes to adults, really, you're just assessing, have they had a flu vaccine or a pneumonia vaccine? And now these days, did you get your COVID vaccine? So again, it's the objective data is the physical exam. That's the inspection, palpation, percussion, auscultation, and any labs or tests, okay? So now let's go across that assessment across the lifespan. Are you guys good? You need a break? Any questions? Anything I can help you with? Keep talking, keep it going. Okay. So, oops, sorry. The infant. All this information. Now, this is what I'm going to tell you, because if I was you, I would be looking at all this like, oh my God, I don't even know how I'm going to remember any or all of this crap. Just kill me now. But when it comes to assessment, the physical exam, first of all, pediatrics is a specialty, and everybody knows that. You are not, especially in this program, because you don't have a separate peds class, you know, you're not going to be expected to know every little detail about peds. When you go and take the NCLEX, there will be some questions about peds, but it's not going to be so detailed that the answer probably wouldn't be any different for an adult. When I go over the infant assessment is much very different from an adult assessment. So the infant portion of this lecture will be a little bit longer versus adolescents, school age kids, because by the time you get to that age, the expectation is the same for an adult, the assessment is the same, all of that. So when it comes to studying, I would, one, vital signs you need to know, usually just heart rate and respirations when it comes to the variations in age. For the infant, you do kind of want to know that infants' temperatures tend to run higher than older children and adults. So having a temp of 100, 100.1, 100.2, those are normal for an infant, and it does not indicate fever. Versus old adults, old people, their temperature runs lower. They tend to have lower, a lower temp. And they don't tend to get fevers as quickly as a child would. So those are the things you need to know, like vital signs. No one is ever going to ask you about a blood pressure of a kid. I didn't even want to put it in these slides, but I just put it on there because I know how students get, and you think you need to know all this stuff, but you don't. You do not need to know a normal blood pressure of a pediatric patient to pass NCLEX. So I would not be wasting my time trying to memorize all the stupid ranges of blood pressure, because they're so stupid and so, it's just stupid. Don't worry about it. Now, if you go into peds, of course, yes, you need to know these things. But for the sake of becoming just a basic, I don't want to call y'all basic, no RN, well, there are some basic RNs, but not y'all. But just for the sake of becoming a registered nurse, a new registered nurse, you don't need to know the ins and outs of peds, just the basics. And that's what I want to give you, just the basics. So for the infants, you want to know heart rate, definitely temp is higher, and that their respiratory rate is higher. Even for newborns, it's like 40 to 60. I am not going to talk about newborns because you will go through, newborns have like 100 reflexes you need to remember and all that. We're not going to that today. Uh-oh, somebody got their mic on. Got a question? No. Okay. So newborns, you will get the newborn assessment from OB next semester. So don't even worry your little pretty heads about newborns. But for infants, you do need to know their developmental milestones. You need to know, have a general concept of how the infant develops. Head circumference is something unique to infants and toddlers. You're going to be measuring head circumference till at least usually 2 years old is when they stop measuring it. So head circumference is something that you're going to measure at each, if they were coming to the doctor, each visit or whatever. Okay, when you're measuring a baby, you usually are not going to start standing them up on a scale or measuring them that way until about 2 years old, because that child needs to be able to stand completely independently. If mom has to hold their hands, then that's going to throw off the weight on a standing scale. So for babies, you're going to lay them down in that little, whatever they call it, the little bassinet thing. Look, peds, I don't work in peds. I know peds because I'm a family nurse practitioner, but it's not my forte. And I know for a fact you don't need to know too much in depth about peds to get through this program. But you're gonna, what's called, like, I put terms in that might come up on your exam, and then I explain them. So like, they call it, you're laying the baby in the recumbent position. You're laying the baby on their back and you're gently, hold their head down, hold their legs down so that they are fully extended and you can measure their height. For babies, it's length because they're laying down, but height, length, you can use them interchangeably. The weight, like it said on the previous slide, their weight should be tripled by 1 year, I believe. And for the head exam, I'm only putting in here the things that are different from the rest of the exam you do for any other patient. So for a head exam for a baby, you do want to look at, for an infant, you want to look at those fontanelles. Does everybody know what fontanelles are? Okay, fontanelles are the soft spot, on the baby's head, the soft spot. When you're born, those bones in the skull have not completely fused together. So you do have basically an opening in your skull, and that's that soft spot. When the baby's born, there's actually a bunch of fontanelles, but the two that might be palpable, and the posterior probably might not even be palpable, is the posterior and the anterior. There's one in the back of the head, and the anterior is in the front. It's in the top front of the scalp. And that anterior fontanelle should be closed by 18 months. Measuring head circumference could give you a sign that the fontanelles aren't closed, or if their head is increasing in size quickly, maybe they have hydrocephaly or something like that. Hydrocephalus is fluid around the brain. So then those babies have big heads. And we'll talk about that, like disorders. What I want to do is, as each concept comes up, each disorder, I will touch on how it affects kids and infants, or if it even affects them at all, or if there's any, like say when we go to cardiac, there's special heart conditions, congenital heart defects that obviously don't have to do with adults. Well, I mean, it could cause you lifelong issues, but we'll talk about both adult, like coronary artery disease, and congenital heart defects. Neck, just need to know by 4 months, an infant should be able to support their head. The mouth, I just put in there because thrush is common, oral thrush is common in babies. However, milk on the tongue can also be easily misconstrued for thrush, when really you just needed to wipe the mouth out. The chest shape on babies is different. It's perfectly their chest size and the circumference around the chest and thoracic cavity. It is basically a perfect circle. Whereas us adults, you know, obviously, if you look at me straight on, my AP, my anterior, posterior, looking that direction, obviously it's going to be wider across than if you look at me standing to the side or lateral, looking at that side of my chest is obviously going to be a lot less narrow. Newborns and small babies, if you're measuring chest circumference, place that measuring tape at the nipple and measure around. There's no way around it. I wish I could. I'm gonna try to find some different worksheets for you guys to like practice and help you. But the two things I will tell you, you do probably need to be pretty darn familiar with and memorize is the developmental milestones for babies and children, which really most of them are the infant and toddler, really. You do need to know those developmental milestones of infants and toddlers. And you do need to know all of the stages of Erikson's development. Those you cannot get around. And I wish I could tell you, you don't need to know this whole doggone table, but I can't guarantee that because any of these milestones could come up on your proctored exam, your exit exam, or NCLEX. So those are things you do need to know about peds. Blood pressure, not so much, but knowing that there could be something wrong with a baby who is, say, 16 months and unable to bear full weight on their feet. Those things you need to have a general idea of that. Cognitive and psychosocial development. So Erikson's trust versus mistrust, like we said, the infant is basically dependent on the caregiver. So they develop trust based on that relationship. Are their basic human needs being met? When I cry, does somebody come pick me up? You know, when I'm wet, do they change my diaper? That trust versus mistrust is the first stage of Erikson's development. I don't even know how to say the man's name, Piaget, however he pronounced his name. Not so much. I would still become familiar with those two. And I'm gonna, I forgot to upload this tool, but I'm gonna upload a bunch of resources after class. But his stages of development are a little more complex and usually don't come up on any exams. It's more the Erikson's. Oh God, can you give me 1 second? I'm sorry. Hello. I don't know. You have to look up that type of printer. And yeah, no, I don't know. You have to look it up, but they probably have it at Walmart. They might, if they don't have it there, they definitely should have it at Walmart because the printer was sold at Walmart. But every time I go there, it's sold out. Okay. Bye. All right, sorry about that. Need some ink in my printer. Anywho, okay. So yeah, age appropriate behaviors, we see that, right? Social language and development. Again, going through the infancy part of this is going to be a little longer just because there's just so many things different for them. Crying is really their only form of communication in the first few months. But crying can help you assess for problems, assess for pain. And I don't know if you read your book, but I know from firsthand experience that babies born to drug addicted mothers, babies who were exposed to drugs, especially cocaine or heroin in the womb, will have an unconsolable, high pitched, like shrieking kind of cry. And they have a hard time with that trust versus mistrust, and they have a hard time kind of like forming that bond initially because they're high on cocaine or yeah. or heroin, whatever. Cooing is like that ga ga ba ba da da. Cooing should begin around 3 to 4 months. By 9 to 10 months, even though I don't know about your kid, but it seems to take much longer than 9 to 10 months, but they should be able to somewhat comprehend no, according to ATI. 3 to 5 years, 35 words should be spoken by 1 year. They usually could say like mama, dada, maybe baba or some other word, but that's pretty much it by 1 year. Separation anxiety usually starts 4 to 8 months. So the term anticipatory guidance, that is a term used in peds only, and it is another word for health promotion, anticipating what type of teaching or guidance that the patient or the parents are going to need, what kind of things are coming up in the near future that they need to be prepared, what kind of things about prevention. Look at mom in the background trying to learn something. Hey, mom. I know, right? My son's 15. He doesn't know what it means either. I don't know. Maybe in middle adulthood they learn. So as far as anticipatory guidance, so you are anticipating the things you need to teach these parents about. Car seats. A lot of things with infants, children, adults, not adults, adolescents, has to do with prevention of risk and injury. The leading cause of disability and death in small children, infants, adolescents, one of the top leading causes is usually injury of some sort, something that could have been prevented. So a lot of the teaching for infants, for young children, is geared on injury prevention. You're going to teach them about car seats. You're going to teach them that the little baby is supposed to be in the car seat facing, backwards towards the back of the car. Do you know how many people do not know that? It's supposed to be facing the back of the car until about 2 years old, or unless you got one of them big old babies, until they're tall enough. Aspiration. Don't lay your baby in the bed with a bottle propped up so that they can choke to death on their milk. Don't get me wrong, I had my baby at 19, so all these things they tell you not to do, I think I did all of them, and thank the Lord my child survived. But then I learned all those things were not to be done. So don't prop the bottle up. Don't have little small toys and trinkets and things in the baby's crib. I know people are religious, or, you may want to have a rosary or something. No, the baby could choke on that and die, okay? Put a cross on the wall or something above the crib. But don't have small objects around them that they could choke on. Prevent burns. Both babies and old people have very thin skin, and the decreased ability to sense changes in heat or temperature. So they don't know, if the water's hot or not. Make sure, and they are at high risk for burns. So make sure, you're not heating a bottle up to 300 degrees in the microwave. And the reason I put this crazy mess on here, some of the people who took the Proctor last semester could tell you, I believe there was a question about the hot water thermostat. Otherwise, I would have never thought about that, but I put it on here because it was similar to one of the questions on the Proctor last year or last semester. Well, it was last year. Water safety. Obviously, you're not going to leave an infant in the tub, in the sink. You're not going to leave a baby anywhere near water by themselves. SIDS is a big one. SIDS, sudden infant death syndrome. This will likely come up on NCLEX. It will likely come up on exams in the future of this class. The thing with SIDS is you want to prevent sudden infant death, usually caused by suffocation. Back in the day, moms were taught to lay their babies on their belly. But then they realized, dang, all these babies are suffocating to death. So they came up with a slogan, back to bed. One of the first things you teach a parent about preventing SIDS in an infant is back to bed. The baby needs to be laid on their back. They should be in their own sleeping space, in their own crib. You do not want to sleep in the bed with the infant. I told the class yesterday, probably one of the most devastating things I've seen a lot of devastating things, but one of the worst was having to sit with a mom and her dead 3-month-old baby, while, she was going through that. I worked in the emergency room for almost 7 years, and I saw a lot of stuff, but this mom had slept in the bed innocently enough with her 3-month-old baby and woke up with a dead baby in the bed. So it is not a good idea to sleep in bed with your baby. It happens. I've seen that, and I have seen it more than once. I have seen infants die simply from sleeping in a bed with the parents, rolling off to the side. Anything can happen. So they need to be in a crib. You don't want some big old plush mattress in the crib. You just want, something thin. You don't want big stuffed animals, anything that's going to put them at risk for suffocation. Now, nutritional guidance, and this is pretty much it when it comes, and then the response to illness. Okay. Nutritional guidance, mainly breast or bottle fed for the first 6 months. I don't know, everybody's culture is different. Some cultures just are intent on these babies need to gain weight and they need to eat and add cereal to the milk within the first month. That is not the guideline. Their digestive system is not ready for that. So for the sake of ATI and this book and NCLEX, you should not be introducing anything other than milk until 6 months of age. If they are breastfed, they likely are not getting enough iron from the breast milk, so they will need iron supplements. And okay, and then solids are usually introduced at 6 months. Like I said, the first solid you're going to introduce is the cereal, the little baby cereal, and then you can move on to fruits and vegetables. But you only want to introduce one new item at a time and space it out like about a week, because remember, you don't know what these little people are allergic to. They've never had these items before. And if you give them 2-3 different things, you're not going to know what they're allergic to, and you may increase the risk of them having a reaction to all this new stuff being introduced to their system. So that's that. Next is the infant's response to illness. Obviously, they don't really know what's going on. So, hold on one second. I don't got time for this. Okay. So they're unable to describe what's going on with them. They're unable to describe symptoms and everything. You can't explain anything to them. So really all you can do is, honestly, your intuition and your assessment skills need to be on point when taking care of an infant, and need to be on point with anyone who's not able to verbalize and tell you what's going on. They may have exaggerated stranger anxiety and bigger, meltdown, screaming and crying versus normal. The biggest thing when taking care of any pediatric patient really is the family. Families tend to freak out, obviously, when their baby's sick. They go through the grieving process, and we'll talk about that this afternoon, but they're scared. They feel guilty. Did I do something wrong? They're pissed. Maybe they think it's your fault that there's something wrong with their baby. All of that is just part of grief. They're really just scared. As a nurse, I will tell you, you're going to encounter all types of people. Me and Nolan were just talking about that you're going to come across all types of people. Everybody isn't going to like you, no matter how great you are. Everybody, different strokes for different folks. Shoot. Everybody, you're going to encounter people who maybe they're racist, maybe their beliefs are different than yours, maybe whatever the case may be. At the end of the day, we're here to provide a service. Don't get too caught up in your feelings. Don't get your feelings all in here. Check yourself at the door before you even take your assignment, because you don't, I mean, obviously if somebody's literally abusing you, you can always go to your supervisor and have your assignment changed. But 9 times out of 10, usually your supervisor doesn't care and you need to work through it. So you have got to work through those issues before addressing people. And when you're dealing with parents and they're freaking out, the worst thing you can do is, you know, tell them, oh, you need to calm down or something like that. For the parents in the room, I'm sure you could imagine your doctor or nurse telling you, you need to calm down when your baby's got this tube going up their nose and everything. They can't grasp the concept of calm down right now. So the best thing you could do is kill them with kindness, be attentive, be quiet, listen, and validate their feelings of concern. And that goes for mental health, and all those exams are going to take in mental health. You never want to minimize what the person is going through. You don't need to be telling them, oh, I know exactly what happened because my baby had this. No, they don't give a damn about your baby right now. Their baby is in crisis. They are in crisis. So now's not the time to be sharing war stories. It is about empathy. It is about being a good listener and feeling for that person without feeling sorry for them and putting them beneath you. So when we move on to toddlers, really, you just need to know the vitals again, mostly just heart rate and respirations is probably the only thing that will come up on an exam as far as vitals. Physical exam of toddlers and preschoolers is pretty much almost the same, except for like the head circumference. You usually stop measuring that after toddlerhood, after like 2 years old. Some doctor's office, they may measure it till 3 years old, you know, especially if it's like a ped specialist, a pediatrician's office, they may do that. The stature of a toddler, as we all know, they have those little bellies that stick out, and they have a prominent lordosis, or that arched back where it's like the little butt sticks out and then the belly sticks out in the front. That is prominent lordosis, and that is normal for a pediatric patient. I mean, for a toddler, sorry, not pediatric patient. Okay. For toddlers and preschoolers, I mean, the head to toe assessment is the head to toe assessment. It doesn't change. You're looking at the same thing. Skin, heart, lungs, all that stuff is the same for a grown person as it is for a child. But for kids, for these little guys, they're scared. They probably don't like you. They don't want to be here. They're probably crying from the moment they get there. So you want to perform the exam in a non-threatening environment, hence why pediatric units and pediatrician offices always have like cartoons and stuff on the walls to make the environment non-threatening. Some jobs, if you work like at a pediatric hospital or pediatrician's office, they may even go as far as to say they don't want you to wear scrubs, or you can only wear the scrubs with the, you know, cute cartoon characters. The whole point is you want the patient to be comfortable. You don't want to intimidate them. Same with mental illness. When you're working in psych, you don't want to intimidate them wearing that white coat, or usually when you work in psych, they have you just wear regular clothes so that it's easier for you to build that rapport and the trust with the patient. Don't just come in a room and start doing an assessment on a toddler or a preschool, unless you're working in the emergency room and this is like a life and death situation and you really don't have time to play. But usually, if you're coming on, you're working on a peds unit and your patients in this age group, you're gonna wanna, well, any patient you wanna develop rapport, but with these kids, you're gonna wanna play with them a little bit. Hey, you know, let them play with your equipment, let them listen to your stethoscope or those kind of things. That's how you build rapport with a child. You're going to explain stuff to them, but you're going to use age appropriate, stuff. Okay, I'm going to look at your belly now. Let me see your belly. Look at that belly. Little stuff, like you're talking to a toddler. And don't tell them, hey, Tommy, we're going to do your abdominal assessment right now. No, they don't know what the heck an abdominal is. Definitely utilize the parents. Parents are going to be your biggest ally when it comes to examining children or performing procedures on children. You want to let the parents maybe hold the kid in their lap, things like that, to help you get through this visit and get the information you need. And then any painful procedures, shots, looking in the ears, anything that's going to aggravate a patient, save it for last. Don't start. That's not how you build your rapport. Because if you come in giving them a shot first, you'll never get a physical assessment. They'll never calm down. Every time they see you, they're going to scream. So save the shot for last, so then you can get out of the room and they can forget about it. One thing I forgot to say too, back to infants, as far as painful procedures, rectal temperatures are the most accurate. And not until about age 3 do you start using the thermometer under the tongue. So for toddlers and infants, rectal is obviously the most accurate. So in a hospital setting, when the patient is acutely ill, you might see, when I worked in the emergency room, we didn't do anything but rectal until age 3. Only because we're in an emergency room. This is an emergency, allegedly, that you're coming here for, and we need the most accurate information. But if it's not infection related and you really don't need that accurate temp, like obviously they don't have a fever, then you can do an axillary temp. These are the developmental milestones of toddlers. Again, like I said with the infants, between those two tables, the one for infants and this one here, which I took literally word for word out of ATI, you need to know these. And however you do it, whether you make flashcards or what have you, but you do need to have a general idea of the developmental milestones. Cognition and psychosocial development for toddlers would be autonomy versus shame. Anybody who has a toddler knows that, Lord, they just want to be so independent. Something clicks around age 2 and they think they know every doggone thing. They can do everything themselves. They don't care. They don't care about your perspective. They can do it. Do you want help? No, I want to do it. Everything is about autonomy and maintaining independence. And hence, this is the time when they're going through potty training. So, and what Erickson believed was that when toddlers do not achieve this autonomy and they are not able to do stuff independently, they feel shame. So we have to promote that independence a little bit and, let them work through stuff because that's part of their development. I mean, don't let them kill themselves, obviously, but sometimes you got to just let them work it out. Even if, they're going to keep trying to turn the sink on to brush their teeth 50 times before they finally have a meltdown and ask you to do it. But just let them do it. Let them have at it. Pre-operational stage with Piaget, or however he says his name, is the main thing I want to tell you is that toddlers are egocentric. Like I said, what they say goes. For example, I have a 15-year-old. My boyfriend's son will be 4 next week. Last week, Wednesday was my son's birthday. And so we're telling him, okay, we're going to go out. Today's Isaiah's birthday. No, it's my birthday. No, Jamari, it's not your birthday. Yes, it is. My birthday. But your birthday is in 2 weeks. My birthday. Okay. We can go back and forth till we're blue in the face. That toddler is never going to accept that today is not their birthday. Why? They're just too egocentric. They just don't care, and they don't care about your point of view. So trying to rationalize stuff and explain stuff to a toddler is basically pointless. So these are just different activities. You can read that in ATI. What are the age appropriate activities for a toddler? I mean, obviously you're not going to give them a book to read. You're going to give them, thick crayons, fingerprints finger paints, things that are going to enhance their development. Anticipatory guidance. So this is the health promotion stuff you're going to be talking to parents about. You're going to talk about temper tantrums. How do they discipline the toddler? Do they discipline the toddler? Discuss potty training. How's it going? Potty training could be a very frustrating time for parents. But most kids get it when they're ready, some a little later than others. And wetting the bed usually doesn't go away until last. So you may have a child wetting the bed, in the school years, and hopefully my little brother, you don't want to be like him. He was wetting the bed till about 12, 13 years old. Nobody was spending the night at our house. But yeah, so you just want to encourage them with that. Dental care, now these toddlers pretty much got a full mouth, a lot of teeth going on, so they need to brush their teeth regularly, and floss, and talk about bedtime fears, because now as they're approaching toddlers and preschoolers, they start to have that magical thinking. They believe in monsters, aliens, all that stuff, the boogeyman. So talk about that stuff, language development, and the same, injury prevention. Look at these two on the right, about to blow the whole house up over here with their surge protector. That type of stuff, injury prevention, protecting these children from killing themselves. That is your role as a parent. Toddler response to illness. Both toddlers, the main thing with toddlers that is peculiar is that they will have regressive behavior. They will go backwards in development. They will act like a baby. They may cry more than they normally would. They may start talking like a baby. They may start crawling. Even though it may seem peculiar to you, it is a perfectly normal response to illness. That is what toddlers do. And then of course they have separation anxiety and all that. Just like with infants, you want to encourage and educate parents every step of the way, give them reassurance, and encourage the parents to be involved in the care. I know it's the hospital, but to make your kid comfortable, the parent really should be trying to work with them with the feeding, the diapers, anything they can do. Do I want the parent to start their IV? Heck to the no, but the things that parents normally do, you should still be doing that stuff in the hospital. Like, if you're capable, it makes the child more comfortable. And then autonomy. You want to encourage autonomy. Autonomy is another word for independence. You want to give them choices. Like, okay, yeah, I still got to give you the shot, but hey, when it's over, do you want a green or a yellow Band-Aid? Which one works for you? When I draw kids' blood, what I usually do if I'm using like a Vacutainer, I will give the kid the tubes, and either they can hand me the tubes to use and draw their blood, or I'll even let them, with some guidance, attach the tubes to the Vacutainer so that they feel like they're a part. And now they don't even care if they got a needle in their arm. It's all good. They feel, like they're doing something cool. As far as preschoolers, we already went over the physical assessment. The only thing is the vital signs are starting to become more like a normal adult. Heart rate can be a little bit higher. Just like with toddlers and infants, it all depends on the activity. Those infants, even though the ATI says what the normal heart rate is 160, shoot, get them babies crying, their heart rate may be up to the 180s, 190s. And if a baby has a fever and they're crying, it may be over 200. Because of course, fever speeds up everything. And we'll talk about that next week with infection. We're almost there. Don't worry, guys. We're almost at lunch. Developmental milestones. This is the last of the Mohicans as far as those milestones. So it's 3 tables. I'm sorry, I lied. But as best you can, memorizing really the gross and fine motor developmental milestones for these kids. For preschoolers, they are experiencing initiative versus guilt. It's pretty much similar to what toddlers are going through. They got independence. They're trying to learn. They're big. They're ready to experience the world and learn different things. So when they're unable to accomplish a task and they need your help, they feel guilt. The only difference with them is by preschool age, as they get to 4, 5, 6 years old, they should be able to consider the viewpoints of others. They shouldn't be so egocentric. You should be able to explain to them why we don't do this or why you should do that. They're also magical thinkers, so they start having imaginary friends and all the imagination running wild. Those things are normal. They start to have a little bit of a concept of time, yesterday, tomorrow. No, we're not going to do that today, but we'll go tomorrow. They understand that. Whereas a 2-year-old, they don't know what I want, and I want it now. And if it's not now, I'm going to freak out and act crazy in this Walmart. So that's the difference with the development of preschoolers, is that they should have a little bit more control over that and not be so egocentric. Again, age appropriate activities that are consistent with their stage of development. The preschoolers' response to illness, well, they are a little bit older. They do understand a little bit more, but they may not always be able to describe their symptoms. An example of that is just saying, like, when a toddler, somebody says, okay, my tummy hurts. They may be able to tell you tummy hurts, but for a toddler, tummy hurts could mean, like, for example, my boyfriend's son, oh my gosh, anything. Oh, I want to watch Spirit. Oh, no, we can't watch Spirit right now. Oh, my tummy hurt. Boy. So for him, tummy hurt just means, oh, somebody's going to give me some more attention if I say my tummy hurt. I don't know where he got that from, but whatever. But tummy hurt could mean I'm hungry. It could mean, so they can't really characterize much more than that. Preschoolers tend to have more fears because they're the magical thinkers, so they might think a scary monster is going to come get them or whatever. Separation anxiety. Also, they may look at, okay, I'm in the hospital. I must have been bad. I'm a bad kid or whatever. And now I'm in the hospital. Right. Christina talking about bedtime for, yes. Toddlers, there's something else. I don't know what to say about them. I don't know. I'm glad my son is 15 because I commend you, parents. So basically with the preschoolers, because they're older, you do want to try to give them choices. Just like the toddler, you want to promote some independence. Like, don't have a 4-year-old using a bedpan if he could get up and walk to the bathroom, unless he's got like some serious heart condition and you don't want him to walk. Encourage them to express their feelings, validate their fear. It's okay to be scared, buddy. I know this could be a scary place. Like, validate their fear. Validate their feelings, telling them that they shouldn't be scared or, they need to calm down or whatever. They don't do anything for a kid. They don't care about that. Make them, as best you can, feel comfortable. Allow toys that allow for emotional expression, like a little hammer, those little like hammer toy that you hammer the little shapes through, if you know what I'm talking about. If not, don't worry about it. But yeah, allow them to, or maybe they want to use their doll to explain something. Oh, and that was something here, was the animism. Animism in your book, they talk about animism. That is thinking that objects are alive. So saying, oh, my dolly doesn't want, you didn't give my dolly a kiss before bedtime. That's animism. You're thinking an inanimate object such as a doll or a chair or whatever is alive. So there's that. So here again with the school age children, it's just the vital signs. which are pretty much, to be honest, like they're pretty much the same as a grown adult. But for the sake of NCLEX and exams, usually when you are being questioned about a child's vital sign, it's usually going to be an infant or newborn, because their vital signs are so much different than adults. So like I said, heart rate and respirations and possibly temperature, but usually just heart rate or respirations on an infant or toddler is most likely what would come up on an exam. Special considerations. As these kids get older, for parents who have older kids, you notice that all of a sudden they start needing privacy for everything. Like, what the heck you need privacy for? You don't even got nothing. Talking about, oh, don't come in here, I'm undressed. But you're 8, you don't even have anything, and I'm your mom. But no, that's normal for them. They're starting to be aware of their bodies and they want privacy. And we should respect that. Not like an infant where you could just throw their diaper off, and they don't have a choice. You just stripped them nude in front of everyone. That's the other thing. Make sure when you weigh babies, you take that diaper off. That diaper could be loaded with pee and make a huge difference in their weight. So make sure when you're weighing infants that they are naked. Infants only. Okay, older children, obviously now they're getting older and they're approaching adolescence. So I still didn't fix this. I'm gonna fix this slide later, but they're able to accept different points of views and understand more. So you're going to explain more to them. You're going to assess for scoliosis starting at age 11. Around age 11, older school age children, you test for scoliosis. Scoliosis is an abnormal curvature in the spine. It is highest risk is usually females in their adolescent or pre-adolescent years. So around age 11, you start checking at the annual exam and everything, you're checking kids for scoliosis. And that curvature is like, normally your spine is up and down, like a straight line up and down. But if you had scoliosis, it would be more like a S shape with a lateral curve. Lateral meaning the curve is from side to side. Prepubescence, so around 9. And honestly, with the hormones and the food in America, for girls, it's actually 8. 9, 8 years old, sadly to say, kids are approaching puberty a lot earlier than maybe they were 30 years ago. Girls obviously are usually faster than boys. During prepubescence, it's mostly just a rapid growth spurt. They're getting taller, they're gaining weight. That's why there's a certain time when it's like all school age children, the girls are all super tall and then these boys just look like little shrimps. Girls start to look much older than the boys. And that's pretty much it. And then their permanent teeth, they start getting all their permanent teeth, including those molars in the back. And they should be done, I think by age 14. Don't quote me looking ATI, but usually it's like around age 14, 15. 14 kids should be done getting all their molars. And then of course, later on in late adolescence, early adulthood, then they have the wisdom teeth. All right, we're almost there, guys. Erickson's industry versus inferiority. These kids are in school. They're looking at their peers and they want to be able to compare and compete with their peers. They want to be on that same level with them. They want to fit in and they want to be able to accomplish the same things that the people around them are accomplishing. So they feel accomplished when they are able to compete and compare with others. When they don't, of course, then they feel inferior to others. And that is that. Concrete, operational. What that means is they get away from that magical thinking. And that's why I put hashtag facts. They start having more conceptual, factual thinking. They aren't talking about monsters and fairies and all that, but they better not be, not by age 12. They learn to tell time. They're obviously able to express themselves through conversation, yada, yada. And then the age appropriate behaviors. Now they, at school age is really when kids should start playing organized sports. Because like everything else, if you put a toddler, I mean, you can do it, it's fine, but they don't learn anything about sportsmanship or anything. They don't care. Have you ever been to a toddler's soccer game? The other team loses and here comes your kid. We won. No, you guys didn't win. Yes, we won. They don't know what's going on. They're toddlers. They just care about themselves. Everything they says goes. But at school age is when you should introduce organized sports. Anticipatory guidance, again, health promotion, obviously the injury prevention is across the lifespan. So injury prevention is a big one. At this age, you're gonna start talking, and even preschool, if the kids comprehend stranger danger, okay? It's 2021. If you like me and you watch IDTV all day, this is a crazy world we're living in. Children are a vulnerable population. They are at risk for being victimized, kidnapped, sexually abused, even by the people closest to them, parents, unfortunately. So you want to teach these kids every assessment, every encounter with any patient, you should be looking out for signs of abuse, or something's not right. You are a mandated, when you get that nursing license, you are a mandated reporter of abuse. If you know that somebody is being abused and you don't report it, you are an accomplice to that abuse and you have allowed that person to continue being victimized. So you want to teach kids about private parts, only I do need to look at your private parts. Now, remember, only doctors, you only show those parts to your doctor or mom and dad, but no one else should be looking or touching your private parts. You want to assess for signs of precocious puberty. Precocious puberty is signs of puberty that are starting even earlier than 8 in girls or 9 in boys. They start developing breasts in 1st grade, or if they start having menstruation in 3rd grade, you're going to want to do some further testing. It could be nothing. It could just be a phenomenon that just occurred, or it could be a sign of some sort of genetic or hormonal disorder. Teach your parents about firearm safety. Unfortunately, we hear a lot of sad stories about kids shooting themselves, shooting their peers, playing with mom and dad's gun. So you want to teach them about that. By early childhood, they eat about half the amount of adults, but by age 12, and especially if you have a boy, them kids are eating the same, if not more than an adult. Talk to them about bullying, cyberbullying, the use of social media and technology for the older students. And then curiosity about sexuality. Their bodies are changing. They have questions, they have thoughts. I mean, younger children, because of the things they're exposed to in the media, they know more. And I'm not about to get in no big discussion with everyone, and this is only my opinion, and I can respect anyone else's opinion, but in my opinion, people are born with their sexual identity, with their gender identity. I don't think that is something that someone wakes up and says, I'm gay. Don't get me wrong, it's 2021, everybody wants to be a trisexual, but I mean, for those who are, you may see kids in their 3rd or 4th grade talking about having feelings for other kids the same sex. So not age appropriate. You don't need to sit here and have a whole sexual conversation with a kid, but you want to at least make sure they're not believing some crazy myths, and make sure that their self-esteem is straight, and there's nothing wrong with them. There's nothing wrong with having thoughts about sex. There's nothing wrong with being attracted to the opposite sex. But you're 12 So, while I invite you to express those feelings, I would also let you know that you really don't have to worry about that stuff until you're 30 years old. You don't need to worry about sex, but I'll still educate you about it. Um, School age child response to illness, obviously, they are more aware. They have the ability to rate their pain on a numeric scale, and they could tell you, they understand cause and effect. They understand when you say, okay, this is what this virus is doing to your body, or if you take this medication, it will heal your infection or whatever. So you want to provide them factual information, but of course using age appropriate language, and encourage contact with their peer group. Maybe they're in the hospital, but they're also doing online learning. I would encourage that kid to be in the hospital with their laptop. Make life, you want to make life as normal for them as possible while they're going through being sick. When it comes to the physical exam of adolescents and adults, again, it's the same, people. It's the same head to toe assessment. Vital signs, everybody should be familiar with those. So I'm not going to even waste my time reading this to you. You should have had some exposure to a head to toe assessment. Now, when it comes to adolescence, puberty. During puberty, the final 20 to 25% of height is achieved. Usually girls are pretty much, once they start their period, they're done growing. They're usually at the height they're going to be. However, males tend to grow all the way till they're like 21. So eventually they catch up with the girls, and then they end up towering over the girls. Acne is a common thing, with puberty. I had horrible acne during puberty, and I wouldn't wish it on anyone. Menarche is just the term used. That is the medical term for your very first menstrual period. So menarche is the onset of your menstrual period. And these two things on the bottom is just listed in the order that they occur. So for girls in puberty, breast development is the first thing that happens. That's why you do see younger girls, third grade with breasts, but they're still totally little kids, they just happen to start developing breasts because that's the first part. Then they start having, more pubic hair, and it gets darker and it's more coarse, and the axillary hair are up under the arms. And then the last stage of puberty is the menstruation, the start of the period. For boys, the order is how it is up here. It's the testicles enlarge first, and then later you have the penis enlarging in length and in girth, whatever. Okay, so same pattern of hair growth, where the pubic hair is first, followed by the axillary. But then for males, they start growing facial hair, and then the last thing for them is their voice changes. Know these Tanner stages. Have a general idea of Tanner stages of development. This is the development through puberty. You likely will get a question about Tanner stages sometime, whether it be on my exam or on the NCLEX or on the exit exam. You may hear something about Tanner stages. Again, like with peds, it's all like the stages of development that are mostly things you'll be tested on. It is very unlikely that you'll get any test question about like some random illness of newborns, like PKU, stuff like that. You don't usually, because like I said, peds is a specialty. Even if you were to graduate school and go into pediatrics, your job is going to make you take a whole bunch of extra classes, because nursing school did not prepare you to be specialized in peds. That's not what we're here to do. So here's that. And you can look through the Tanner stages. Cognitive and psychosocial development of adolescents. Like I said before, they're looking for that identity versus role confusion. You may have an adolescent like me. I think I probably went through every phase a kid could go through in 8th grade. You know, one week I was goth. The next week I was like looking like a raver. The week after that, I was a hardcore thug. You know, I didn't know. I was trying to figure out my identity, and I had a lot of role confusion. So that is normal. That is a part of adolescence. So and they are identifying with their peer groups. Peer pressure is the biggest thing. You know, my philosophy on parenting is, you know, I'm going to do my best to guide my kid and lead him, steer him in the right direction. But I am not an idiot. And I know that most of the stuff that your kids learn, honestly, is through their peers. That's who they are influenced. That's who they're most heavily influenced by. And even as adults, we deal with peer pressure all the time. Um, Formal operational, would an 11-year-old that already has their puberty be considered an adolescent? They're pre-adolescent. Nope, adolescence doesn't start till age 12. But you know, they're probably experiencing they're probably, if they've already gone through puberty early, then they probably already at this psychosocial developmental stage of identity versus role confusion. The other thing is, it could be the opposite. The sad thing, I feel bad for kids who do develop super early like that, and then mentally they're just 8, you know, they're not thinking about anything sexual, and that's why these kids are at such high risk for being victimized when they are developing so quickly physically and not so much mentally. But yeah, an 11-year-old is still in the prepubescent stage. They're still a school age child. Piaget, you know, whatever, you know, like I say, you really need to be more focused on Erickson's age appropriate behavior. I mean, you know, you want to encourage non-violent, age appropriate stuff, you know, try to keep them away from the Grand Theft Autos and the gangster rap music and things like that. But it's 2021. I mean, a lot of stuff you really can't, all you can do is educate and hope that your kid makes the right decision, sadly. So anticipatory guidance and health promotion, again, like I said before, adolescence is going to be geared towards reducing risky behaviors. As soon as I get through this adolescence, we can go to lunch. So it's going to be safety and injury prevention, wearing seat belts, you know, they're learning how to drive, they're riding in cars with friends, all that. So there's going to be safety and injury prevention. Really, you want to focus now on risky behaviors like I said, substance abuse, sexual practices. You know, I mean, of course, you want to promote abstinence, but we've all been in high school. Is every single high schooler abstinent? No. And if you have a good rapport with an adolescent patient, they will be upfront with you. They want to be viewed as adults and they want to be independent. So, I mean, you do have to have conversations with these adolescents and not just turn the other cheek. Maybe you can't you can't make them abstain, but you can really press on them about safe sexual practices. And then you want to talk to them about bullying, cyberbullying, social media, and preventing obesity, which is like the biggest thing kids are faced with these days. Again, adolescents are pretty much like adults. So you want to treat them like little young adults. While some, this is why I hate peds, because I cannot stand dealing with parents, you know, because some adolescents, I mean, they know their bodies. I don't need mom cutting the patient off every question I ask because, you know, you have this overbearing mom in the room. So when you're dealing with adolescents, one, you want to allow them, even though it's hard to do, you do need to allow them time to express themselves. Sometimes you got to ask a parent to step out of the room. Part of my assessment, you know, like if you're examining a sensitive body part on an adolescent, give them the opportunity to say if they want their parent in the room or not. You know, not every 16-year-old girl wants their mom to see their breasts. So just be mindful of that and what adolescents are going through. So it's 12 o'clock. It's probably like, I don't know, less than 10 slides left. It's just a handful. Do you want me to finish now or do you want to go on break now? Either way, you still get an hour for lunch. Finish up, wrap it up. Okay, I'm gonna wrap it up real quick. It's not much left. I'm sorry. And if I'm talking too much, please let me know. But anyway, like I said, this lecture is a lot because I'm trying to go through the entire lifespan. Normally, you would have a whole semester of peds to go through all this, but we're going to go through it before lunch, all of it. So don't worry. And we're going to reinforce it all throughout the semester. So for young adults, they have intimacy versus isolation. You know, that's when you're getting married, you're meeting, you know, your soulmate, or you hope to meet your soulmate, you know. You're making, you know, strong friendships. I don't know about you, but I don't really got many friends from high school or growing up. You know, my closest relationships have occurred during adulthood. And when they don't achieve that, that's when they feel isolation. Generativity is those middle adults, you know, they're either their kids or adolescents and they're growing up. And, you know, maybe they're even as they get older, they're becoming at this time, you know, the state of the world we're living in. I mean, middle-aged adults are usually grandparents now. Shoot, my mom was a grandparent, I think, either in between 40, 42, something like that. And that's, I mean, I'm not saying that's totally normal, but it is common. It's very common. So they're looking at what is my legacy? What is my life? How have I contributed to the world? How have I contributed to my children, my grandchildren? How have I contributed to the younger generation in society in general? If they look back on their life and they've just been drinking and you know, partying their whole life, they're going to start to feel some stagnation. You know, at some point that partying stuff gets old and you want to naturally have made an impact on the world before you die. So this is that time, 30s, 40s, 50s, when people start thinking about that. And then, of course, older adults, like I said before, it's about maintaining their independence and their integrity. When they feel like an invalid, when they're facing incontinence, immobility, if their independence is not promoted by us, the healthcare workers, they are going to feel despair. They are going to feel depressed. Older adults are at high risk for suicide also. You know, they feel like their life has lost all meaning when they can't do anything for themselves. So it is our job to promote their independence. And that is how you approach, you know, health promotion for them. For young and middle-aged adults, it needs to be geared at routine screenings. I have posted a document from the United States, National Preventive Services Task Force. This is a real task force. And if you were in nurse practitioner school or becoming a doctor, you will be very in tune with this list. This is the list of recommended health screenings. And most of these screenings are occurring in middle adulthood. That includes who should get mammograms and at what frequency, who should get a prostate exam, how often do we counsel about obesity? How often? So take a look. It's just a list, but the United States National Preventive Services Task Force is a group of people who have put together this list. And when you're doing health promotion in middle adults, you really need to be going over those routine screenings, how often they need to be coming in and getting a physical, because again, everything is about prevention. Because we do pap smears so diligently, cervical cancer is like not, it shouldn't be a concern at this. I mean, we do pap smears and we have so many great treatments that cervical cancer can be caught so early and nipped in the bud. Most people who die from cervical cancer are women who were not getting routine pap smears. And I'm not saying that about everyone, but majority, 90+% of the time, if you died from cervical cancer, it is usually because you were not getting regular pap smears. Same with like mammograms, colon cancer. Those colon cancer is one of the most treatable cancers there is. The problem, but it's also the most one of the most common. And the problem with colon cancer is that stigma of getting a colonoscopy. Many men, and especially, you know, in certain cultures, many men are like, hell no, I won't go. And they don't want a colonoscopy, whether they think it like emasculates them or whatever. But, you know, all of us saw last year when a Black Panther, what's his name? Chadwick Boseman, when he died. And I don't know if you guys, I mean, I'm not trying to be too ratchet, but if any of you guys are familiar with the TV show about 10, 15 years ago, it was a show on VH1 called I Love New York. And there were two brothers on there competing for this woman's, you know, attention and affection, whatever, but Chance and Real. The character Real, he died after being on that show at age 29 from colon cancer. So again, if you get it at an early age, that is, you know, probably not as avoidable. But I mean, if you're getting your colonoscopy age 50 and up as scheduled, usually they can find precursors for cancer and nip it in the bud. You're gonna, just like adolescents, you're gonna encourage safe sex. They may need screening for STDs periodically, at least once. You know, you want to check for HIV, another disease that honestly is so easily treated, and we'll talk about that next week. But yeah, and then obviously substance abuse, mental health issues. I'm gonna let y'all read through all this, and I'm gonna post a little resource for changes, physical changes in the older adult. But you know, obviously things slow down and stuff hardens, stiffens up, and production of certain cells is reduced, and everything just slows down. So it makes you know, your physical exam, although you're doing the exact same assessment, your findings, you're gonna find some variations with older adults that's totally normal, like liver spots and things like that. And like I said, I'll just load something in the Moodle because I don't got time to go through every single change in adults. But as we go through different diseases, I will always touch on age, what goes with what age group. Special considerations. Obviously, you need to assess the mental status, you know, make sure they don't have dementia, assess their functional status. You wouldn't believe how many people come in it is frightening how many people come in the hospital and the doctor's office completely demented. You know, somehow by the grace of God, somebody found them because they done fell in the home 3 days ago. And, you know, now they have rhabdomyolysis and all these issues because they live alone. Or you would be surprised how many people are living alone and completely demented out of their mind. I don't know how they survive, but a lot of times the first time this is caught is in the hospital. When something happens and they end up in the hospital, and then the healthcare workers are like, wait, you live alone? Like, what the heck? So you want to assess their functional status and their ability to perform ADLs, their ability to keep themselves safe. You want to assess that. Assess for incontinence. That's something, you know, that's going on with them. Depression, like we said, they can feel despair with all this stuff going on. Psychological needs, signs of isolation. Finally, this is like the last little couple slides, and that is only on diseases, or alterations in development. So we have chromosomal abnormalities. Those are genetic disorders. They're passed from your parents. It's due to certain genes. At least half, if not most, miscarriages are due to some genetic disorder. So that is that. Risk factors, obviously, the older the mother is when they're getting pregnant, it does increase risk factors. I was just talking to somebody yesterday about the, large number of children we see with autism. And really, I think one hypothesis is that people are waiting later to have babies. Like, we all want to get a career and go get 4 degrees, whereas like back in the day, our parents and grandparents, shoot, they were having babies. Your whole purpose in life was to procreate. So, waiting later to have babies certainly put your kids at very high risk. And especially when the parents are closely related, like cousins or brothers and sisters. That just makes it that much worse. Family history, obviously, some genetic disorders, like I said about sickle cell. If one of your parents actually has sickle cell disease, you're going to be at risk for getting sickle cell disease. So knowing your genetics, that's why they do all that testing and take a really intense history when women are pregnant. And then any exposures to infection or toxins during your pregnancy. So Down syndrome, also known as trisomy 21. Trisomy 21, it's called that because that is that particular gene that is affected. But for the sake of knowing, you don't need to know like the ins and outs of genetics to become a nurse. You're not becoming a geneticist, whatever. You're not becoming a rocket scientist. But you need to be familiar with the clinical presentation and the nursing considerations for Down syndrome. So the picture you see, these are the classic appearance in Down syndrome. I think everybody in the class has seen someone with Down syndrome before or went to school with someone with Down syndrome. It is the most common genetic disorder there is. And while a lot of people think it's just about the appearance and maybe like some mental disability, they actually tend to have a lot of medical problems. A lot of patients born with Down syndrome have cardiac, genetic heart defects. They have congenital heart defects. A lot of them end up with leukemias, very common. So just to know that. Risk, again, is the maternal age, things we said before. Testing. The main testing you need to know is that they could do what's called an alpha fetoprotein test during pregnancy. But they may not. Say the mom is 22 and healthy and has no family history, they may not do an alpha fetoprotein. And if that's the case, and the child is born with this, this distinct face, facial appearance and things like that, then you're going to do genetic testing on the infant. You may do echocardiogram, which is an ultrasound of the heart to see if they have any abnormalities. When it comes to treatment, obviously you're going to be more concerned with like the heart or things like that. So they could have surgery to fix those things. If they have leukemia, treating them for that. But there is nothing you can do to correct Down syndrome itself. I mean, you can give growth hormone because they are so short in stature. Growth hormone will help those children grow. Because they a lot of times are like dwarfs. Parent education is just everything you see here below. Giving these parents support. The Cool Mist humidifier is one thing that stands out because they are at risk for dry mucous membranes and they're at risk for constipation. So talking about fluid intake and other ways to increase, bowel movements. and avoiding respiratory infections. And also they tend to have, you always see these down, and I'm not trying to be funny, but it's just true. You see people with Down syndrome, you always see them with some super thick glasses. That is, or you might see them with hearing aids. That's because most people with Down syndrome do have visual or hearing impairment. Here's another video, not gonna play it, but you can play it on your own. Oops, when you go home or whatever later. Oh heck no, what just occurred? What happened? Screen. Oh, here we are. Okay. One more developmental disorder, or really a movement disorder, is cerebral palsy. Most common movement disorder. Cerebral palsy is almost like a collection of symptoms, really, because it comes from brain damage that usually occurs in the belly or in pregnancy or during the birth. For example, when a child is born with the umbilical cord wrapped around their neck, that is going to cut off circulation to the brain and oxygen to the brain, and can result in cerebral palsy. So risk factors are right here: any existing brain damage, head trauma, premature babies are always at risk, certain maternal infection, exposure to toxins, if there are multiple births, and obviously maternal drug use or malnutrition is always going to be at risk for any problem. So as far as diagnostics, they do a MRI of the brain, and really you can look and see the symptoms that the patient is having, the neurological assessment, and the doctor can usually diagnose it off of that. But of course you're going to want to explore, where is this brain damage? I did put a link in Blackboard, and you could check it out. That's where I got this picture from, but it was just a page. I like this website just because it really showed more pictures and of the different types of cerebral palsy. I can promise you, you don't need to memorize like different types of cerebral palsy. As long as you have a general idea of what is cerebral palsy, again, what are the clinical manifestations, and what is my role as a nurse. That's really all you need to know about every disease. You're not going to school to be a neurologist or a neurosurgeon. You just need to be able to identify the disease and know what things to look out for and to educate the patient. What'd you say? Is somebody asking a question? No? Okay. Swear to God, 3 more slides. Okay. So that's that. As far as cerebral palsy, it could be identified, early at birth, but it may take some time, to see that your child is not developing the way that they are supposed to. There may not be any obvious sign right at birth for a lot of diseases. It may take time for the baby to go home and the parents to pick up on something, or for them to come to the doctor and they see, okay, they still have those primitive milestones. Primitive milestones are like all those newborn milestones. They may have difficulty swallowing. They may not be able to suck on their bottle, tongue thrust, poor head control, yada, yada. So these are the physical things you're going to see. Here's the different types of cerebral palsy, but like I said, I wouldn't get too hung up on them, but you can look at that website that goes with this little handout there. Management of cerebral palsy, again, the neurological assessment, you may do some genetic testing, but it's really just looking at the physical appearance, their movement issues, and that scan of the brain to see what's going on. You're going to address the patient. That goes for any patient. I don't give a damn if the patient's in a coma, You don't know what that person can hear. Our role is to maintain human dignity. We are to treat people with dignity at all times. My biggest pet peeve, make me want to just slap somebody, is when I see a nurse or anybody talking about a patient as if they're not even human, as if they're not in the room. I don't care if the patient is demented. I don't care if they have cerebral palsy and they can't talk. You don't know what degree that patient understands. And golden rule, you treat people the way you want to be treated. So you're going to address the family. Hey, Tommy, good to see you. Tommy may not say anything back, or he may just moan. It doesn't matter. Just acknowledge them. One, for the patient's dignity. Two, because it makes a family comfortable too. Treat them like a human. You want to address any role stress that the parents are going through. When addressing the patient, you're not so much concerned with their age, but more their developmental maturation. And that's with anybody. Meet people where they're at, not where they're supposed to be or you expect them to be. If your patient is 40, but they never went to high school and they kind of have the mentality of a 12-year-old, then work with them like a 12-year-old. Don't try to be condescending, talking to people in a language they just can't understand. They may need some alternative communication, things like that. Airway is always most important. So you want to prevent aspiration. You want to teach them about using their devices, their wheelchairs, all that. Medications. Baclofen is a muscle relaxant. Of course, with cerebral palsy, the majority of their issue is they've got that the muscle spasms or hypertonicity and like stiff, tight muscles. So the treatment, the only medicine to give them is really just muscle relaxants and anything to prevent seizures. So as far as baclofen and diazepam, they're both used as muscle relaxers. Baclofen is either oral or through a G tube if they have that. The other way it can be given is through a pump, an intrathecal pump. That is a pump that's surgically implanted by a spinal surgeon, and it pumps it straight into their nervous system. You are not going to do nothing with that, okay? The doctor, when the medicine runs out, the doctor who's managing that, they will put that in, not you. So you really just don't even need to worry about that. Both baclofen and diazepam can cause hepatotoxicity or liver problems. And just think about that. If a drug is filtered through the liver, it has the potential to cause liver problems. If a drug is filtered through the kidneys, it has the potential to cause kidney problems. It's that simple. So if your patient already has a liver problem, you likely will not give them a drug that needs to be filtered through the liver. You don't want the liver to have to do any extra work. So it's that simple. Diazepam, only additional thing to know about diazepam is that it's a controlled substance. It's the generic for Valium. So it is a benzodiazepine. But with any muscle relaxant, you want to make sure they don't have respiratory depression, muscle weakness, lethargy, yada, yada. Another possible treatment will be Botox. Especially like in the quadriceps, you could give a direct injection, IM, and that could help with that. Anti-epileptics, like I said, anything, if they're having seizures, that could be something you need to treat. Dopaminergics, we will talk more about the effects of dopamine and dopaminergics when we get to neuro and Parkinson's, but basically it just mimics dopamine and promotes relaxation of the muscles. Interprofessional care, that's just the referrals. You're going to refer to physical therapy. Physical therapy are the ones who order wheelchairs, canes, those kind of things. They order any wrist brace, knee brace, anything like that. So they need physical therapy, not only for the actual therapy and stretching and range of motion exercises, but for braces and devices. They are the ones who order that. Occupational therapy is for fine motor skills like feeding yourselves, performing ADLs, dressing yourself. Occupational therapy will help patients develop that skills. And if they need any special feeding utensils, like they make big oversized spoons and things like that, they can get that. Speech therapy not only works on speech and talking, but also swallowing. This next slide is a video. Let me get up out of there. And it is just showing you cerebral palsy. It's a doctor talking about it. And it's just like a minute or two. But you can watch that on your own. Spina bifida. I got spina bifida, failure to thrive, and go to lunch. So spina bifida, neural tube defects. Neural tube defects, really, you shouldn't see this so much anymore in 2021, but it does still happen. Neural tube defects means there is something occurred during the birth and the spinal bones did not close properly. So now you have this opening where cerebrospinal fluid, the fluid that lubricates the spinal cord, is leaking out. That is a meningocele. So you have this little area, and if you see this baby's back here with this bubble here, what happens is, so they had this area, but now fluid's leaking out, so it forms this sac. If the sac only has cerebrospinal fluid in it, it shouldn't affect them neurologically. They should likely still be able to walk and everything. Unfortunately, that form of spina bifida is less likely. Usually, patients with spina bifida have a myelomeningocele, and that sac contains not only cerebrospinal fluid and meninges. Meninges are the protective layers around the spinal cord, but it also has nerves. Now, because the nerves are coming out of the spinal cord, they're not going where they're supposed to, and they can't transmit messages. Now that person probably can't walk, or if they walk, they might be able to crawl, but they're going to have neurological issues. What causes this? The biggest risk factor for spina bifida is a folic acid deficiency and poor nutrition. So because this was such a big issue, that is why our foods, our cereals and things are what you call fortified. They are fortified with iron and folic acid for the sake of decreasing birth defects. So because in America, our diet is fortified, spina bifida is almost non-existent. It's extremely rare these days, but you know, back before, I don't know, whatever year they fortified cereals, the 80s, 70s, this was much more common. So this is a video, again, telling you about spina bifida so you can get a better understanding. And last slide, failure to thrive. Okay, so failure to thrive, it honestly affects adults as well as babies. It can affect anyone, but in an infant, that would be those babies who are either less than the 5th percentile in weight, or these babies who are showing a pattern of consistent weight loss. That picture right there is the same baby. So something happened to cause that baby to be, you know, starved, basically. And it can happen for a number of reasons. It could be an underlying illness going on, cancer, something like that. Or it could be what they call intrauterine growth restriction or growth retardation, which can happen when mom's on drugs or malnourished, or exposed to certain medications or chemicals during pregnancy. It can happen as a sign of neglect. Maybe the parents aren't feeding the baby. You know, these things happen. It could be a sign of poverty. Maybe these parents, a lot of times, people confuse abuse and neglect for what is just the straight up consequences of living in poverty. Sometimes parents are doing the best they could possibly do with the hand that they were dealt. So maybe formula is expensive as crap. And maybe if you have a very young mom who is trying to make it on her own, and no one ever told her about the WIC program or food stamps or anything, and she can't afford formula, so again, you have to try to put yourself in other people's shoes and come from a place of understanding. We are here to promote health. We are not here to be the guardians of morale and all that. Okay, everybody has a different life experience, and we need to appreciate that and do our best to just keep patients safe and promote health. The treatment is really about parental education and support. Sometimes, like I said, if you can't help what you don't know. So parental support, frequent visits to the doctor to keep monitoring the weight. They make Ensure and other little, supplements for babies. And then tube feeding or IV therapy obviously will be the last straw if we can't restore their nutrition. Same situation occurs with older adults. Older adults, especially like with dementia, when their cognition is going down, things like that, they can start to have failure to thrive. And that is how older adults, a lot of them end up with a G-tube. A lot of people with cognitive issues do have issues with eating and maintaining a good nutrition. So that's it. That's all she wrote. I'm sorry it went longer than 12, but it is 12:30. So we will go on lunch until 1:30. Let's say 1:35. Okay, we'll make it fair. 1:35. We will meet back here. I don't know how your other teachers did it. I don't know what to do, if I should stop the meeting completely, or did you guys usually keep your Zoom open? What'd you guys do?
My other professors just like left it open.
We never use Zoom though.
I think you said what?
We never used Zoom. We used
Tutor, right? Yeah, when I used to use Tutor, I would just have the meeting end at 12 and then a new login, but we'll just, turn your mic and your camera off, or if you feel like y'all want to talk amongst yourselves, go ahead, but I'm about to get the heck out of here and get me something to eat. So 1:35, turn your mic and your camera back on. Yep, keep it open. I know, RIP Chadwick. It was so depressing. But yeah. All right, so hopefully I didn't bore you to death, but if so, you got an hour to take a nap, and then we'll see you at 1:35.